I'm presenting this on behalf of our team and the Lancup team and Stuart Cook, and it's to discuss how we have approached the old problem of mortality reviews. From 2007, NHS Lanarkshire requires all inpatient deaths and deaths within 30 days of discharge to be reviewed as part of their commitment to lowering HSMR. All deaths require a mortality review, and this was traditionally done with a paper review form that you can see on the right-hand side of the screen. Feedback from this was that it was onerous, stressful, and was difficult to use in a meaningful way. Stuart and his team at Lanquip worked collaboratively with clinicians to develop an electronic solution to this challenge. Our challenges were around engaging clinicians in the process and releasing clinician time for this to happen. We needed to build a system, and this required development time, testing environments, and capacity. And it required to be user-friendly so that the clinicians that were using the service could engage with it and use it easily. We had a further challenge in trying to identify what data we wanted to extract from the system, who would we be extracting it for, and what data would be useful. Which part of the data we collect would be useful to the service, which would be useful to the clinicians, and overall, how would this improve the patient care that we deliver? Over 2 years, we worked collaboratively to develop an electronic system within Lanquip. The new system is available via Firstport, and users will be invited to complete a mortality review via an email with a URL link that would take them straight to the case to be discussed, or they can access it directly via the Lanquip 2 section on Firstport. After users are invited to complete a mortality review, either via an email with a URL link, or you can access it directly via Lanquip 2 on Firstport, you'll see this screen. And the username and password is the same as you would use to log into any other computer. When you log in, you're presented with a Lanquip home screen. On the left-hand side are your tabs to input data into the mortality system. For ease, I'll just describe how to complete a mortality review. Select morbidity and mortality, and this should bring you an option to manage your reviews. When you select this, the screen changes, and you have 4 different tabs along the top. For the purpose of this, we're going to select mortality reviews. Under here, you will find how many incomplete reviews have been assigned to you, and you will also have the option to look at how many reviews you've already completed. This might be useful for appraisal purposes or reflection later on. If we select the reviews that are incomplete, these should appear with the patient's CAI number and name under the mortality system. For clarity, these are all dummy patients. There is no patient identifiable data here, and as you can see, these are all nonsense CAI numbers. To complete our mortality review, we will select a patient here and click the screen to view. When this occurs, what you should find is that the KI number, the date of birth and the date of death is already pre-populated. You as a reviewer should have your name here, and then you have the option to select the review date. The responsible healthcare professional that was involved in the patient's care during life should be here, and also the specialty to which they were admitted, the location they were in, and the ward area. It will also have pre-populated their final discharge ward and hospital. The mode of admission should be pre-populated, but you can change this should you wish, from transfer to emergency to elective. The admitting condition can be selected here also, depending on what the patient has come into hospital for. For medical patients, it's likely to be ward related. The admission time and date should be here. If the patient underwent any procedures, you should have that option here. Again, for medical patients, that's unlikely to be something that you need to complete, but for surgical or anaesthetic patients, that should be selected. The discharge date reflects the date that they died or the date that they were discharged from hospital, should you be completing this review for somebody who died within 30 days of discharge. The discharge diagnosis is a free text box, and that allows you to either put in the cause of death that was on the death certificate or the discharge letter, or the discharge diagnosis when they were discharged from hospital if they died within 30 days of discharge. For example, we can add in pneumonia, and atrial fibrillation. The next part of the form allows you to describe briefly the circumstances of the death. Did they die in hospital? Was it an anticipated death? And again, all of these questions should be answered in conjunction with using the clinical portal record of the patient's care. In your opinion, was the death anticipated? Was the death certificate available for you to review? And did that accurately reflect the diagnosis? Was the death certificate reviewed by the medical reviewer? You may not know that at the point that you're doing this review, in which case select unknown. If you know that the case was discussed with the procurator fiscal or not, you have the option to select that. Was there evidence of community planning prior to admission, particularly for patients who've had unexpected death? This information can often be gained from using the EKIS summary on clinical portal under emergency care. Did the patient have a hospital anticipatory care plan during this admission? And that either may be a hospital anticipatory care plan or a treatment escalation plan that we've been using more recently. Was the palliative care team involved in the patient, particularly in patients in whom death was expected? And did they have a documented do not attempt cardiopulmonary resuscitation document? And if so, was that completed correctly? And the definition of how that was completed correctly is here. Was the discharge summary present in clinical portal at the time that you did your review? Was the patient boarded out of specialty? And was there any concerns identified by the family, anybody else, or yourself after reviewing the death and the notes? Were the family or carers involved in discussing the eventual outcome? And importantly, was there any evidence of futile treatment? When you've reviewed all of that, you get the opportunity to identify whether or not the death was expected, with all appropriate management being undertaken. Was death expected and something wasn't done? Was death unlikely, but all appropriate management was undertaken? Or was death unlikely and all appropriate management was not undertaken? If you've not got any concerns and it was unexpected death, you can select number 1. And even if the death was unexpected, but all appropriate management was undertaken, you can select 3. For governance purposes, what we're really interested in is where appropriate management was not undertaken. So if you feel that there was something different about that patient's particular death and you select either 2 or 4, that will prompt you to tell us more information about whether or not there was a system of care issue and what impact that made on the outcome. So for example, we could select that there was a delay in clinical review that was of concern but made no difference to the eventual outcome. And again, there's an opportunity to free text any concerns that you have. When you select a 2 or a 4 death classification, you will be prompted, in addition, to identify other specific comorbidities. For example, diabetes, hypertension, and obesity. If you've identified that there was concerns with a particular death, the next part of the form allows you to tell us what escalation you wish to do. Deaths that are unexpected and where all appropriate management was not undertaken should be reviewed locally at an M&M meeting. They perhaps may require escalation to a significant adverse event review, or they may require an SBAR or a level 2 review. This allows you to select which escalation type you feel is appropriate. For example, discussion at local M&M meeting. It gives you the opportunity, particularly for surgical patients, to identify if there was a specific complication that needs discussed. And there should be a function where you can fit the particular case into a pre-established morbidity or mortality meeting. These morbidity and mortality meetings can also be identified and set up by the Lancook system. So it should allow for a seamless transition between death review and local learning. You may find that the learning from the case happens sometime in the future when you discuss it at a mortality meeting. If this is the case, we would encourage you to save and continue the form later. And then after the mortality meeting occurs, come back, identify any learning, and then mark it as complete. To demonstrate how the reporting functionality works, when we're back at the Lanquip home screen, if we select reporting, that should open up a folder for morbidity and mortality management. As you can see, this allows you to select an overview dashboard. In this example, if we look at the mortality responses, this gives an example of the number of patients who had an accurate death certificate, who had accurate discussion with families, and whether or not there was any concerns raised by family, by the reviewer, whether there was a completed D&E CPR, and when there was every evidence of futile treatment. And this gives you some understanding of the deaths within your service. For individuals, it might be useful to know how many death or morbidity reviews you've completed. Here you can see the number of mortality reviews that have been completed by an individual and the number yet to be completed. And this data can be used for individual appraisal for governance purposes. It might be important for your service to manage how many reviews are incomplete, either to support clinicians that need more time or experience in completing these, and also to make sure that the distribution of reviews, particularly in high volume specialties such as care of the elderly, are distributed evenly. It also gives an oversight as to how many deaths are occurring within your service on a monthly basis. And that's important to measure activity, particularly for high volume specialties, where the number of death reviews requiring to be completed may be very high. Similarly, for specialties where there's a number of high morbidity reviews, such as surgical and anaesthetic specialties. Death type and those types of death that require escalation beyond local level can also be recorded. I mentioned earlier the opportunity that we have with this software to populate meetings, such as morbidity and mortality meetings. This can be configured by the lead within your service who allocates the death and morbidity reviews. So again, we select under the tab here, Meetings Management. This should open up a calendar. And within this calendar, you have the opportunity to invite interested parties to our morbidity and mortality review meeting. To do this, you simply select on the date that you wish the meeting to occur on. That gives you the opportunity to title the meeting, location, and which team is important for your specialty to be there. The date and time can be set, and by saving the meeting, it appears within your calendar. To manage that meeting, select it and click Manage. Again, this opens another screen with tabs along the top. One of the useful functions of this is that you can invite colleagues to the meeting via email. For example, if we select Add all team members, the list of clinicians within your team will appear here. If you wish to invite them to the meeting, you simply click Confirm, and that clinician or colleague will be invited to attend the meeting by email with a time and date. You will have a list of invited colleagues on the right-hand side, and when the meeting occurs, you simply click Present, and that will update the number of attendees who have attended the meeting. There may be patients who have already been entered into the morbidity and mortality review meeting as part of the mortality reviews. And you may find that their patient details appear here with their CAI number if that's already been requested by the doctor that does the review. However, you also have the opportunity to add a mortality review. And if you select here, again, these are all the dummy patients that we could select to be discussed at the meeting. Finally, when the meeting occurs, real time, the system allows you to update any actions generated, which should hopefully translate into learning. So for example, if you have a patient whose death you're reviewing, in which case there are some actions that have to be completed by the team, you can add a new action. It gives you a target date from which you can specify when the action has been completed. It allows you to update when the set action has been done. who it was assigned to, and allows you to manage whether the status is open or closed. And that should provide real assurance that whatever we discuss at our morbidity or mortality meetings generate an action plan and an opportunity for learning. And then we would expect, after that death had been reviewed, that the individual who initially completed the mortality form could go back to the original review and update the learning at the bottom, as we described earlier on. And you would save and mark as complete. Certainly we feel we're engaging people better. It's useful for appraisal, and it may be more accessible for home workers who can't get access to the paper records in the hospital. The technical access has improved accessibility. It's probably better for the environment because we're not handling lots of paper. And it's COVID secure because we're not having to touch and handle lots of different pieces of paper. The data functionality is a big improvement. The dashboard is a most recent addition, but I think there is some benefit to this. And I think as we go forward, the data we extract from this service is likely to be very beneficial indeed. So the next steps are to spread and scale. We've been testing this in Monkland since around about 2018. I believe here Myers are starting to test it now. The morbidity functionality is being tested by the orthopaedic team at Wishaw. And in support of this video guide today, I believe Langquip are going to continue to provide video guides and support, and we hope that the dashboard implementation will continue to roll out through 2021 and 2022. I hope that's been helpful. The Langquip team would be on hand to answer any questions you might have, and I'm also happy to answer any queries that you may have by email.